All right, like she said, I'm Dr. Elkin, Chief Medical Officer over at Trustpoint Hospital. Trustpoint Hospital is a med-psych hospital, meaning we treat people with depression, psychiatric illness, people that have had strokes, people that need rehab, schizophrenics, alcoholics, people that have, tried to commit suicide, etc. We treat a lot of different types of people. And today I'm going to talk a little bit about opioid abuse. It's been been in the news a lot lately, and I'll go ahead and get started. In general, what is an opioid? It comes from the poppy plant up here. It's derived from the poppy plant. It's made of morphine and codeine. Morphine and codeine are referred to as opiates. Heroin is made from morphine and is called a semi-synthetic drug. Fentanyl and Dilaudid, which you've probably heard about in the news, very strong narcotics, are opioids and also synthetic drugs also. And they act just like opium. They bind to receptors in your brain. They cause pain relief. They cause euphoria, which can lead to addiction. And they have multiple potential side effects, including constipation, sedation, respiratory depression, slowing your heart rate, along with other symptoms. Opiates are in opium. They include morphine and codeine. And opioids are manufactured as semi-synthetic opioids from an opiate. For instance, heroin from morphine. Synthetic opioids also exist. One of those is methadone. So how do opioids work? They trigger a reward in your brain by attaching to a receptor called the mu receptor in the dopaminergic system. They can cross the blood-brain barrier very quickly. A word called lipophilic just means that it can cross that blood-brain barrier, the fat lipid barrier there, and it can lead to the reward pathway very quickly. This is the reason that heroin is preferred over morphine as a drug of abuse. So opioid agonists, there are different types of medications and there's treatment medications to treat opioid abuse also. These are known as opioid agonists. All that really means is that it attaches to the receptor in the brain. When it attaches to the receptor, it can lead to different symptoms. Some of those symptoms include euphoria, the feeling of pleasure. It can lead to nausea, vomiting, depressed respiratory rate, sedation, analgesia. They can be used for pain relief, obviously. They can cause itching. A lot of people on pain medications need other medications to treat their itching, along with altered mental status. If you take too much of an opioid, it can lead to pinpoint pupils. You've probably heard of pinpoint pupils when people go to the ER. It can lead to blue skin. It can lead to fluid on your lungs, along with absent respiration, which can lead to death, along with low heart rate, low blood pressure, and if there's really severe decreased oxygen to your brain, it can cause brain death also. Chronically, once people have been on a pain medication for a very long period of time, as previously mentioned, it can lead to constipation, lethargy, which basically just means being tired all the time. It can lead to tolerance along with dependence. Concerning respiratory depression, the way that works is it basically depresses part of your brain, the medullary respiratory center, leading to a right-sided carbon dioxide response, along with increase in something called carbon dioxide, decrease in oxygen, and decreased oxygen saturation. Sedation, or being tired, luckily occurs before significant respiratory depression, and as a physician we can use this when somebody starts acting really tired. We know that's a warning sign that they may be on too much of a pain medication. So what makes people so addicted to opioids? What characteristics make give this pleasure sensation? What makes them different than other medications? The route that you take it. If you take it in different routes, you get the medication faster. So for instance, injecting it is the fastest way you can get this medication. The next fastest is smoking it. The next fastest is injecting it just under the skin, not into a vein, but just under the skin. That's called subcutaneous. And then lastly, either sniffing it or taking it by mouth and letting it go through your GI system. Heroin versus long-acting medications like methadone have a very short half-life, meaning that they act very quickly. And then previously I talked about lipophilicity. That just means that the blood-brain barrier medications that people will get addicted to more quickly tend to cross that blood-brain barrier very quickly and give them the high very, very quickly. Heroin crosses the blood-brain barrier faster than morphine, which crosses it faster than methadone. So all those characteristics, injecting it IV, having a short half-life, or acting quickly, and crossing the blood-brain barrier make these substances very addictive. So looking at what's happened over time in the United States regarding abuse, and like I said, this has been in the news lately. Since the 1990s, there has been a significant increase in the use of opioids. In 2012, there were 2.1 million prescription drug abusers in the United States. Outbreaks involving opiates are becoming more frequent. In 2015, officials at the Indiana Department of Health became very alarmed. An explosion of HIV cases occurred that were also co-infected with hepatitis C. It was later found that this was due to co-sharing of needles for an opiate called oxymorphone, which is also known as Opana. So over time, the abuse of opiates has gone significantly up, and it really is a crisis in the United States right now. So looking at how do people get addicted, what leads to addiction, how does this occur? Opioids and heroin abuse are very closely related. In fact, 80% of heroin users started with prescription painkillers, and that's key. People don't think that they can get addicted and end up on heroin just by getting a pain medication from their doctor, but they can. And in fact, that's the majority of what happens now, is people get in a car wreck, they have some back pain, something leads them to getting addicted to a pain medication that they get from their doctor. They start taking that too much, they become tolerant to it, they need higher doses, and then later on they may end up getting addicted to heroin because of that. At-risk populations include young adults along with military and veterans. There's been a shift in the demographic of heroin users recently. For instance, when you think of a heroin user, you probably think of a young minority male, maybe in Chicago, and that was the case with heroin back in the 1960s. Abusers of heroin were poor young minority men in urban areas. You think of somebody injecting an IV drug, an illicit drug, but today 90% of heroin abusers are white and live in suburban areas like Murfreesboro, with equal numbers of male and female users. So it's definitely shifted from being just an inner city problem like in New York and Chicago to kind of going all over the United States, into the country, into suburban areas, outside of Nashville like Murfreesboro, etc. So how do people get opioids? How do they get these pain medications? How do they get addicted to them? Friends and family. So this is something, y'all may have maybe getting a pain medication for your back or for a limb or something that hurts. That's perfectly fine. There's nothing wrong with getting a pain medication for something that you need it for. Only when it leads to behavioral changes in your life or where you just can't do without it do you really need to get some treatment for that. But what about like when you go back home to your house? You store your pain medication in a cabinet, and then you have a grandson or a granddaughter or a daughter or somebody else, and that pain medication's been sitting there for 4 months. Oh, grandma's not using this. I'm going to grab it. It's exactly what happens. So the place that people get opioids from are friends or family members. And where did those people originally get it from? They got it from their doctor. So it goes from doctors to patients, out into the world to everybody else. So abusers are either given the drug, buy it from a friend, or steal it from a family member. Rarely do they buy it on the street from a drug dealer like they used to do back in the 50s and 60s. Only 4% of cases is that relevant now. So there's been a jump in prescriptions at pharmacies. In 2000, 174 million prescriptions for opioids were prescribed, and in 2009 it jumped to 257 million prescriptions. So looking at overdoses and opioid deaths, we talked about the fact that it suppresses your brain, causes sedation, causes a decrease in your respiratory drive. It basically makes you stop breathing if you take too much and you overdose on it. And when you stop breathing, that leads to no oxygen in your brain and you go brain dead. The increased number of prescriptions has led to a jump in opioid deaths. There are 16 times as many opioid deaths now versus the year 2000. In 1999, there were 2,900 deaths from opioids. And in 2014, this number is staggering to me. That number has jumped from 2,900 to 47,000 overdose deaths. It's something to think about, isn't it? Car wrecks have decreased since 1980 due to basically people starting to wear seat belts, airbags, cars being safer. Basically, the car industry really concentrating on decreasing MVAs and deaths related to motor vehicle accidents. However, drug poisoning and overdoses has risen above car wrecks starting in the year 2006. So if you look at a graph prior to 2006, there are more car wrecks leading to deaths in the United States, and now more opiate overdoses lead to deaths than car wrecks now. So overdose deaths are mainly due to prescription opioids. They're not usually due to heroin. So who's writing prescriptions? Mainly general doctors, primary care providers. And what's the number one drug that's abused? Number one, and the number one drug that people get addicted to is Oxycontin. It has a very, very, very high abuse potential. So this is just a graph looking at deaths from heroin. On the very left is 2002. It shows approximately 2,000 deaths from heroin that year. And in 2015, it shows close to 13,000 to 14,000. Now this graph doesn't show prescription opioid deaths, just from heroins. But you can see how it's had a significant increase over time. So talking about Oxycontin, Oxycontin is one of the most abused prescription opioid medications. And personally, I don't prescribe it. Looking at the history of Oxycontin, who made Oxycontin? A pharmaceutical sales company called Purdue Pharma. 1996, it was introduced with a very strong marketing plan. They took doctors to the Bahamas and things, and gave them rooms and free vacations at that time. And they sold a lot of doctors that had a lot of pain patients on this medication, but they didn't tell them about how addictive it was. So this medication grew very quickly since 1996, and since then a lot of people have become addicted to this medication, which has led to addiction to heroin and other medications also. So pharmaceutical sales reps got large bonuses for pushing Oxycontin for non-cancer chronic pain. Addiction rates for prescribed Oxycontin are unclear, but some studies have shown it to be as high as 45%, meaning if you take this once, there's a 45% chance you'll get addicted to it. Thus, use of Oxycontin for non-cancer pain increased tenfold, and for cancer pain, it increased fourfold. The company that owns it made $2.5 billion on the medication in 2012, and the state of Kentucky sued Purdue Pharma for misrepresentation and got approximately $24 million at the time. So looking at opioid marketing, the majority of countries don't allow you to market pain medications and opioids, potential medications that might be addictive. The United States and New Zealand are the only two first world countries that have not banned direct pharmaceutical to consumer marketing. So what does the government and the CDC, they're kind of the head of medicine in the United States, Center for Disease Control, what are their guidelines for treating chronic pain? You should use non-opiates, obviously, firsthand. You should try to use something that doesn't have an addictive potential to treat your pain first. You should try to avoid long-acting opiates like Oxycontin, as it doesn't really treat the pain better and there's more overdose potential. And for physicians, we should check urine drug screens, along with there's something on the internet called a prescription monitoring website, which all pharmacies have to put when somebody goes to the pharmacy and they get a prescription for pain medications. If somebody has a significant abuse potential, they'll go to another doctor and they'll get another prescription. And historically, before the internet existed, they would just kind of doctor shop around and get tons and tons and tons and tons and tons of prescription medications. A lot of times they would just sell them. And that's how they would live. They'd make money off that. And so to monitor that and monitoring our patients, we should check urine drug screens and check that prescription monitoring website to make sure that a patient we're seeing didn't get a prescription for opiates yesterday and they're coming to see me today and trying to get another prescription when they just got 30 pills yesterday. This kind of goes into taking a history from a patient, and this is more geared toward medical professionals, but I'll go over a few of these things, and I'll give you some of the examples of when I see a patient, what I'm asking, what I'm trying to get out of them. Always, ask general open-ended questions like, what are you using? are using IV, do you use your illicit drug IV, intramuscularly, subcutaneous, by mouth? Do you inhale it? Do you sniff it? Are you using heroin or prescription opioids? When was the last date and time that you used these medications? When was the last time you didn't use opiates for a few weeks or a month? Because this can lead me to, if I'm trying to treat them, if something worked for them in the past, it might work again. Also screen patients to see if they have a history of alcohol abuse. And also something to know about treating opioid abuse is the use of other drugs is not an absolute contraindication to buprenorphine treatment, which is the main primary medication treatment for opioid abuse. So I might ask questions like, how many times in the past year have you had 5 or more drinks in a day? How many times in the past year have you used an illegal drug or prescription medication for non-medical reasons? Also, when I'm taking a history from a patient, I want to concentrate on alcohol and benzodiazepines, because if I'm going to treat somebody with the different medications that you can treat opioid abuse for, sometimes if you combine those medications with alcohol or like something like Xanax, sometimes that can be a contraindication and can lead to side effects. When I'm looking at their surgical history, I want to make sure that they don't have a pending surgery. I want to make sure they're not pregnant if I'm going to treat them for opiate abuse, as that's also a contraindication. I want to find out, what their psychiatric history is. I want to see if they're stable, whether they're psychiatrically stable to agree to treatment, and whether they're taking their psychiatric medications. Make sure they're not, in a psychotic break right now. Make sure that there's not somebody else that might be their power of attorney that may make their decisions. On physical exam, some of the things I look for include needle tracks, which are things on the arm that show that they've been using needles or IV heroin. Sometimes I look for infections on their arm, around their elbows, etc., where they might be using. You can look at your own family members if you suspect somebody may be using, to kind of look at their arms and see if you see some infections on their arm also, or needle marks. And then we do a pregnancy test, a HIV screen, a hepatitis panel, because all these patients are high risk, and so they're more likely to, if they're sharing needles, they're more likely to get all these diseases. We also do a comprehensive urine drug screen, which basically screens for everything. A normal urine drug screen doesn't necessarily screen for methadone and some other medications. Standard urine drug screen does not test for methadone. And then as far as treatment goes, if they're at our facility at Trustpoint to try to get medical treatment for this, we have to decide whether the patient's actually ready to participate. If they say they're going to go out tomorrow and start using again, obviously they're not ready to participate in our program. So looking at whether the patient has a steady job, whether they've been adherent to going to appointments, taking their medications, etc. That's one of the ways that we know that they're more likely to participate in the program and do well in the program. So what is tolerance and dependence? Tolerance is basically when you have to take an increased dosage of your pain medication to produce the same effect. This can lead to significant side effects, including respiratory depression. Versus dependence is withdrawal symptoms from stopping the pain medication or taking certain medications that you can get in the ER that reverse the effects of an opiate, like Naltrexone. So, why do people get addicted to opioids, and how do they start out as far as their natural history? So they start out from, the first time they take it, they feel euphoria, they feel a feeling of pleasure, and then as that dissipates and that medication stops working, then they feel normal. Then they take the medication again, and they feel euphoria. And then over time, they start going from feeling normal to having shakes and anxiety and sweating and feeling like they have the flu. So they start off going from euphoria to normal, to then going from normal to withdrawal symptoms. And it's usually when they start feeling terrible, start to have these withdrawal symptoms, when they're taking large amounts of these pain medications and they're just not working anymore to give them that euphoria feeling, that they decide to seek help at a medical facility. You don't have to worry about this scale. This is more for medical providers also, but there's a clinical opiate withdrawal scale known as the CAL scale, and the withdrawal symptoms that we look at include anxiety, and you can see the pictures up here to the right include some of these: runny nose, insomnia, not sleeping well, dilated pupils, and muscle aches, elevated blood pressure, heart rate, temperature, along with GI symptoms. You can see the guy in the bottom right picture who's having a lot of stomach aches. So those are some of the symptoms that you get when you withdraw from pain medications or opiates. So how do you treat opioid use disorder? If somebody has been going through some withdrawals, they're not getting that euphoria feeling anymore, they decided they want to get help, you can do different things. You can go see a psychiatrist. Some people just try to taper themselves off the medications themselves. Sometimes they'll just try to take smaller and smaller doses each day, and occasionally that works, but less than 10% of the time does that work. Usually they have to have some type of medication ordered by a doctor to be able to get off this medication long term. So there's different medications that we use. One of them is called Methadone. It's been around since the 1970s. Buprenorphine is more recent. It's been around since the late 90s. And then there's medications that are mainly used in the ER, like Naltrexone and Naloxone, which are mainly used to treat opioid overdoses. But when we treat people, we try to use a team approach. We use psychiatrists that counsel the patients. Most of the time, these patients do have some form of depression, suicidal thoughts or ideations, anxiety in their life, financial difficulties, recent divorces, lots of problems that everybody has in this world. But it's a team approach of using psychiatrists, using nurses, using social workers, and using doctors, medical professionals, to prescribe these different medications. So why do we use medications for opioid use disorder, which is OUD? Basically, the reason is because they work. Lots of studies have been done, but 90% of people relapse without it. There's increased treatment retention and 80% decrease in drug use and crime. 70% decrease in all-cause death rates. There was some legislation done in the year 2000 by President Clinton called Data 2000, which allows prescription of opioids to opioid-addicted patients for the treatment of addiction. And this is where buprenorphine, one of the main medications that we use, came along. And it requires physicians to undergo some training or to be a specialist in addiction medicine to be able to prescribe these medications. Not just any doctor can prescribe these. Only buprenorphine or a combination of buprenorphine and naloxone, which are Schedule III medications, meet these criteria. Hospitalized patients with a primary diagnosis other than opioid dependence can be ordered buprenorphine by physicians that have not gone through this training. So if somebody has pain in a hospital setting, that physician can use buprenorphine in that setting. This is a little bit probably above what needs to be said in this lecture. This is more for other physicians, but looking at the pharmacology of opioids, there's a receptor in your brain called the mu receptor. That's the one that's like the pleasure receptor, and that has a high affinity for morphine. It leads to, there's a process that goes through something called GABA. And methadone is one of the treatments that's been around since the 1970s. Buprenorphine is more of a recent treatment, and like I said previously, the naltrexone is mainly used in ERs. Looking at methadone, how does methadone differ than buprenorphine? Methadone is a Schedule II drug. Schedule I is more like an illicit drug, like heroin. So Schedule II means that most doctors aren't going to be able to prescribe this. It's an opioid agonist, basically meaning it fully binds to the receptor in the brain, which means that it gives you more of a high and can cause more of a pleasure sensation, just like heroin or something else does, but it doesn't give you near the effect that something like heroin does. So there's definitely more risk of abuse for this versus buprenorphine. When you take it by mouth, it works quite well. Regulation, I talked about this previously, but in 1974 there was a Narcotic Treatment Act making it illegal for normal doctors to prescribe this. Only opioid treatment programs are allowed to prescribe this, and dispensing of methadone is limited to licensed opioid treatment programs only. So there are quote-unquote methadone clinics that you probably heard of. This is what this is talking about here. When you go to a methadone clinic, what do they do there? They have daily nursing assessments, which are required. There are weekly individual or group counseling. There's also random supervised drug testing, urine drug testing, along with psychiatric services, medical services. Studies have shown an increased survival and treatment retention, along with better employment and better birth outcomes for people that participate in methadone maintenance that have been addicted to an opiate in the past. So how safe is methadone? It has a fairly long, unpredictable half-life, meaning we don't exactly know how long it's going to be in your body. And it can also cause some heart issues, one thing called torsades, but this is usually with very high doses. Next, looking at a medication called Naltrexone. This is a medication that doctors might give a patient who comes in who's overdosed on a pain medication in the ER. This is basically what they usually get. It completely blocks heroin's effects. If somebody comes in and they know they've overdosed on heroin, the ER doctor is going to give them this. It also, some people use this to prevent impulsive use of the drug. It prevents against overdose, but stopping it suddenly can pose a high risk of lost tolerance. It's not good for most patients because it's not really effective long term, but for very highly motivated patients, sometimes even doctors get become impaired because they get addicted to pain medications themselves. Sometimes this is the medication they use because a lot of times to continue practicing as a doctor, they're not allowed to take opiates or partial opioid agonists if they're going to be working in a hospital setting or working with patients. It can be associated with liver failure, so we try to avoid giving this in patients that have hepatitis or alcoholics, especially in excessive doses, but normally it doesn't affect the liver. It is contraindicated in people that have acute hepatitis or liver failure, and something of note for the medical providers is it requires 1 week off of heroin, opioids, or buprenorphine or methadone. So because of this, adherence can be a problem. So looking at the main medication that we use to treat opioid addiction, it's called buprenorphine. It's also known as Subutex. That's the commercial name. It's a partial opioid agonist, and what does that mean? It means it binds to the receptor, but it doesn't give the person the full high like the methadone does. So it's a little bit safer, and it's less likely to be abused because it doesn't give you the same high that methadone does. Buprenorphine's affinity is stronger than full agonists like heroin, and it'll knock the heroin off of that receptor and bind that receptor, thus preventing somebody that's using heroin from getting the high if they're taking this medication. Buprenorphine dissociation is slow and blocks heroin from binding if heroin users inject. Thus, if somebody is using this medication and they inject with heroin, they're not going to get high off the heroin. Of note, on a standard urine drug screen, this doesn't show up as positive, and that's why we tend to do comprehensive urine drug screens. Some drug interactions are associated with this also, mainly HIV medications and rifampin, which are not really used that commonly in the common population. It is approved for moderate to severe opioid use disorder. It's not approved for mild opioid use disorder, and it's given under the tongue, and you have to wait till it completely dissolves when you take it under the tongue. There are patches that are approved for pain, but they're not approved for opioid use disorder. And in the future, they're looking to try to come up with an extended release injection or an implant that might be used. And that will be very, very effective if they're able to come up with an extended release form. So in general, concerning buprenorphine, as far as the summary, it shows studies have shown that buprenorphine is more effective than not using anything and equally effective to moderate doses of methadone on primary outcomes, which include abstinence from illicit opioid use, retention in the program, and decreased opioid craving. So just to kind of summarize, prescription opioid use in the United States has led to a significant increase in addiction, leading to heroin abuse, overdose, and death. The recent declaration of an opiate crisis in the United States is warranted. For providers, we need to avoid prescribing opiates if at all possible, specifically Oxycontin. Use of medications such as buprenorphine to treat opioid use disorder has been proven, and the safest, most effective medication is buprenorphine, which is proven to be safe, result in very few overdoses, and led to abstinence from illicit opiate use.